So I'd like to thank the support group for inviting me to speak today on immune thrombocytopenia, looking beyond the platelet count. So during this talk, I'd like to review some of the limitations with our current approach to the management of ITP. I'll describe different patient-related outcomes that we can use, and then briefly touch on the concept of shared decision-making. So there's a lot of inherent problems in how we conduct research in ITP. What we'd really all like to do is show that we can prevent major bleeding events. This is what matters most to us and to patients. However, because these events are so rare, it oftentimes becomes very challenging to use that as an outcome for clinical trials. And so for this reason, the platelet count has been used as a surrogate marker for bleeding risk. And the presumption is that an increase in the platelet count will reduce the risk for intracranial hemorrhage. But the platelet count alone may not really reflect the full bleeding severity of a patient, and different cutoff values have been applied to different clinical trials. So sometimes it often makes it difficult to compare two studies if they use a different definition. Some work has been done in this area with a consensus statement coming out of what should be considered a platelet count response. And I think that that uniformity is in some ways at least helping us make sure everybody is speaking the same language when we do use the platelet count. But additional outcome tools are really needed, and our current tools, as I'll show you, are limited, and there really isn't any gold standard measurement tool that's available when we look at different outcomes that matter to patients. So like I said, the platelet count is really the driving force of treatment. And if we look at recent guidelines that have come out and consensus documents, you can see here that most of them start out with defining the platelet count threshold first. So across most of these, a platelet count of less than 20 or 30,000 is an indication for treatment in an adult with ITP. And then they also account for the fact that this would be in a patient that has no or minor bleeding, certainly not somebody who had serious or life-threatening bleeding, in which case we would treat regardless of the platelet count. But there's a lot the platelet count does not tell us. So it really doesn't tell us the true severity of the disease. So in one study, this is some pediatric data that I have, but we showed that, children with skin purpura had a mean platelet count of about 9,000, whereas those with severe bleeding had a mean platelet count of 7,000. So despite very similar mean platelet counts, the bleeding was highly different in these two different groups of patients. So really, if all we focus on is the platelet count, we're going to miss a lot of what's going on. The platelet count also doesn't tell us any medication effects beyond increasing the platelet count. So some medications we think may increase hemostasis. So corticosteroids, for example, have been shown to decrease bleeding symptoms even before the platelet count starts to come up. We can see effects on fatigue or maybe even improvements of quality of life even before the platelet count begins to hit that response criteria. And at the end of the day, what we really want to know is the full picture of the impact of the disease on the patient. So we have to look beyond the platelet count, right? We have to look beyond just the blood draw and the laboratory number to really get this full picture. We have to consider the adverse effects of the drug therapy that we're using. We have to look at the bleeding severity of a patient. We have to factor in health-related quality of life and what does that look like to an individual patient. And then also this concept of fatigue and how our patients are feeling and how they're able to go about their daily lives. So if we start with medication side effects, I think that these are really underemphasized or not even mentioned at all. And when we go to the research studies, what we see is that oftentimes while side effects are collected, it's very vague. There's not a lot of granularity on the frequency, the severity, the time course. That remains relatively unknown. Many of you are familiar with some of the side effects listed here. So for corticosteroids, so prednisone or dexamethasone, these can make the body feel quite awful and are not ideal drugs to use for a long term. IVIG can be related to pretty significant headaches as well as something called aseptic meningitis, and then it is an infusion with fevers and chills and sometimes an infusion reaction. And then Winro, or anti-D, actually works by causing the body to break down some red cells so that a few platelets can escape. So inherently in this drug, we're actually causing the red cell number to get low by how the drug works. and it's actually been associated with some pretty significant side effects, including something called DIC, where you break down too many red blood cells and the body can't support that. And then rituximab, again, infusion reactions, infections, and serum sickness. And this is just a surface overview of what we know of the major side effects of using treatments, and that each individual immunosuppressive agent and the new TPO agents are going to have their own side effect profile as well. So I just put this up there to highlight that the medicines we're using are not without their risk, despite having benefit, and I think we always have to walk that careful balance. And just to highlight this a little bit more, I really like the study. This came out of Jim George's group in Oklahoma. And what they did was they actually surveyed both physicians and patients and sort of asked what they were concerned about. And what they found is that there is a difference in what patients and physicians value in terms of importance. So 80 patients and 83 hematologists replied to this survey. And the patients reported more corticosteroid severe side effects than hematologists. Hematologists seemed to feel as though patients were not having significant side effects. And if they did, they were not considered severe, whereas patients rated them as very bothersome. Physicians, however, were more worried about severe bleeding than the patients were. So if we think about this, the patients were more concerned and more thinking about their side effects, and the physicians were more thinking about the bleeding. And many patients reported feeling as though their physician did not pay appropriate attention to corticosteroid side effects. So again, just highlighting that we need this open pathway of communication, and we need to look at the disease as a whole, again, not just as a number. So bleeding severity becomes a bit tricky. There's really no standard way to measure the amount of bleeding a patient is having. But it's important since bleeding can be different than what the platelet count would predict, as I showed you on that other slide. And arguably at any time, a patient doesn't know what their platelet count is at any given moment. We don't know if a patient's walking around and has a platelet count of 12,000 or 27,000 or 45,000. But what we do know and what we tell patients to call us about is their symptoms. So how can we help better qualify those symptoms and inform patients on how to call us and talk to us? And then when we do research, or when we're talking about patients, how do we make sure we're all using the same language and how we do? And if we think about bleeding, it can have quite an impact beyond just a quantification, right? So if we just take a nosebleed as an example, this could be a situation in which someone is having to leave work quite frequently for nosebleeds. So it's an interference in their daily life. We may have a patient that now needs to start iron therapy for anemia secondary to the blood loss that they've encountered from significant nosebleeds. So now we have a patient that's requiring another therapy or treatment. Another patient is one that has to wash their sheets in the morning because they had a major nosebleed overnight. Or what about a nosebleed that continues so much so that a patient has to end up in the emergency room in the middle of the night? So again, a lot of crossing over between quality of life and bleeding, and it may just not be a simple quantification that really matters. And this quantification becomes difficult, right? So how do we determine what matters more? Is it the frequency of a bleeding event? So what if I have 10 small nosebleeds in one day? Is that any more or less bothersome than having one major nosebleed in that same week? Does the duration matter? Is it the frequency? Is it duration? Is it the timing? The timing may be more inclined to impact our quality of life. Again, is this something that's waking me up at night? Is it happening during an activity that I want to participate in? And then what are the consequences of that nosebleed? So am I losing so much blood that I'm now anemic? Do I need to see the doctor or go to the emergency room? Have I now been started on a new medicine like iron therapy? So I don't know that we can fully separate out bleeding severity from quality of life. I think they're intricately entwined, but I think we can have quantitative measures of bleeding severity. And then within our quality of life measures, which I'll talk about, we can begin to incorporate the impact of bleeding on quality of life. This just shows here some of the publications that have tried to assess bleeding specific to ITP. The first of which was by Paula Bolton Maggs back in one of the most widely applied and first used in research was the Paula Bolton Maggs and Moon back in 1997, which rated bleeding as non-mild, moderate, or severe. And then there's been others that have followed. Some have very site-specific scores as well as an overall score. And work is still ongoing in this area. The most recent measure that was created was in 2013 from an international consensus group that came up with the acronym SMOG for different sites. And then also, and that was rated from 0 to 3 or 4. And there's still a lot of work doing to make sure that this is a good measure to be used in clinical research. The problem with some of our current bleeding assessments, though, is that we need to design them a little bit better with some rigorous methodology. We need to make sure that we're really thinking about everything that's clinically relevant. We need it to be able to really identify those patients that are more severe. So we need to identify the questions that really target patients that are most likely to have a more significant bleeding episode later, perhaps, or that would most benefit from treatment. Most of these have not been validated, and there's been minimal reliability testing. And these are tests that a measure undergoes to really let us know that we can apply it over and over and over again. And regardless of who's doing it, regardless of who's giving it, we're going to get the same results. Many of these also include medical interventions. So a lot of these measures think that bleeding should be considered very severe if it required an intervention, a treatment or a transfusion. And I think there's a little caution in that sometimes this may actually just be a measure of the physician's comfort level, maybe not a direct measure of the bleeding that the patient is having. And then, as I pointed out, there's crossover with health-related quality of life, and we need to make sure that if we capture just quantitative amounts of bleeding, that then our quality of life captures the impact. And if we just strictly think about this from a research standpoint, what we see is that it's really difficult to apply multiple scores. So if I have one score for skin and another for nosebleeds, that's very difficult to use in a research study where I really would like just kind of one number for each patient. So I think we still need more in this area. We need to include all important bleeding presentations. We need to have clearly recognized items that don't depend on an intervention. These might actually also be very helpful to use when a patient's not being seen, so a way for a patient to communicate their symptoms with a provider. It should account for the patient perspective, if not in the measure itself, but in quality of life measures. And then have available site-specific categories, but convert into one overall grade that can be applied when we try to use these in a research setting. So I think health-related quality of life is really the new driving force. I think this is the direction that we need to go in how we communicate with patients and the direction that we need to take our research, because this really addresses what patients are most concerned with at the end of the day. It pulls the whole picture together. It accounts for the impact of the disease on daily activities, and it explores factors that might not be apparent to physicians at the time of a clinical visit. I take this example. This is near and dear to what I do every day. So I see a lot of adolescents, and sports are very, very important to adolescents. You know, and I actually have quite a few patients that come to me that are trying to get college scholarships. And so sports activities become a huge part of their quality of life. This just gives an example of, you know, what we might put as parameters. And you can see that at some point, you know, having a platelet count that restricts somebody from non-contact sports, while maybe not the most horrible platelet count number, can actually be quite limiting if you think about what it is that's important to them or meaningful to them in terms of quality of life. And I think it's important to recognize, too, that quality of life looks different to each patient. And it really takes sitting down and having an open discussion about what are their goals, and then how can we help achieve those. Quality of life can also capture inconvenience. So we have the inconvenience of doctor's visits. Some patients are seen up to even once a week in the beginning. This takes a lot of time from work and school. Taking daily medications. So what does that look like? Particularly adults on chronic steroids, but even having to remember to take medication daily. The clinic time for infusions, if we're doing something like rituximab, which requires somebody to be out all day and then may even impact how they feel for the rest of that week. or surgical recovery. When we talk about splenectomy, we certainly start to talk about surgical recovery times and concerns from a surgical standpoint. And then lost time for hospitalization. So if we have admissions for serious bleeding, and even recently we really did think about this with the creation of the guidelines in terms of what patients truly even need to be admitted to the hospital, recognizing that there's a balance here between wanting to keep patients safe, but then also not wanting them to have to spend days in the hospital, missing time from work and other productive activities. So I'm just going to highlight 2 commonly used scales for health-related quality of life. And some of you that are familiar with some of the research that's going on, or you may have even filled some of these forms out at one point or another. One is the short form 36. This has 8 important areas that were identified. It is not specific to ITP, but it looks at physical functioning, a physical role that the patient plays, bodily pain, general pain, social functioning, the emotional role, and mental health. Each is scored on a scale of 0 to 100, and a higher score means you have better quality of life. This does allow us to compare to other chronic conditions. So even though it's not ITP specific, we've gotten a lot of very good information from having patients complete this survey. When we looked at the SF-36, there was no difference in gender, splenectomy status. Patients currently receiving treatment did seem to score lower, and those with a more recent diagnosis. There is an ITP patient assessment questionnaire, and this started with patient focus groups. So this really was came out of listening to patients and understanding what they felt was important to talk about with quality of life. This is ITP specific. It has 10 important areas that were identified. So you can see one of the differences here is that it does comment on ITP specific symptoms, and then it does get a little bit more into this notion of fatigue. And it looked at women's reproductive health, recognizing that bleeding that women experience may be highly impactful on their quality of life. And this has undergone validity and reliability testing and has been applied in some of the research studies. When we look across this, we do know, though, that health-related quality of life is impacted. Patients show lower quality of life than the general population in almost all areas. Scores in patients with ITP are comparable to patients living with other chronic conditions such as arthritis or cancer. Persistent ITP patients seem to be the group most effective. And then patients receiving treatment had some of the lowest scores, as I mentioned previously. So I think we really have identified that this is a huge area that we need to understand better, that we need to improve our communication, and that we need to apply as an outcome in clinical research trials to really make sure that we're tackling this issue. So the last is fatigue, and this has really, I think, become a emerging area of really understanding that this is an important aspect of the patient experience and is often overlooked by practitioners. It was found that about 12% of patients reported always or often missing work or school because of fatigue based on using a fatigue score, and that 20 to 40% of patients reported significant fatigue when using the same scale, the fatigue impact scale. Specific scales and measures have not really been developed or tested for ITP, and it often becomes a component of the health-related quality of life assessment, although arguably probably gets watered down if we just look at it in that context without a more specific scale. So oftentimes, again, this is why the fatigue impact scale will be used as well as a quality of life measure. There's an unclear correlation with the platelet count, and in speaking to many patients, we hear this a lot, that just because the platelet count is 75,000 doesn't mean an ITP patient isn't experiencing fatigue. Or sometimes they'll say they feel fatigued and it sort of gets dismissed as, anxiety or something else, and it's not really appreciated to be truly a separate entity. And so I think, again, we need to dig a little deeper on perhaps the cause of this and better understanding it. It always makes me sad when I have children that come to me needing different accommodations at school, and the school really doesn't understand why a child would feel fatigued with ITP, and trying to really explain that and get them some accommodations because of how significant it can be. So this is just a quote from the most recent consensus document that came out, the revision in 2019, but I just think it nicely summarizes that patient-related outcomes are essential outcome measures for clinical trials and should be considered in the routine management of adults and children with ITP. And I think that's really the take-home message. And while we may have some work to do on refining and perfecting these measures, we do have them. They are available and we should continue to keep applying them. And I actually think it's time to start bringing them more into our clinical practice, not just reserving them for research studies. So can we make things better? How do we make things better? Well, I think we need to turn our experiences into evidence. We need to find ways to apply consistent patient-related outcomes across research. We do need to start doing some cost analysis. We have a lot of new agents coming out and they all work very differently. Some are, we look at how do we compare splenectomy, which is a one-time surgery, to a TPO or an immunosuppressant agent that requires ongoing use, to a short course of rituximab. They're all very different, and what does that look like? One way in which we can start to think about this, though, is to do studies in a way that's called comparative effectiveness. And what researchers do here is it's up to the physician and the patient what treatment they get, but regardless, we're going to collect the same data on every patient. So if you get a splenectomy, I'm going to collect quality of life and fatigue and bleeding severity on you the same way I am for the patients that get rituximab and the same way I am for patients that go on a TPO. And then we can really start to look at these side by side. We've done a little bit of this early work in pediatrics in our ICON-1 study, which is a US-based research consortium where we did just this very strategy for any patient going on to a second-line therapy, and allows us to look to see if certain therapies are more effective than others with regards to different outcomes. I also think we should never overlook qualitative methods. I think sitting down and talking with our patients in a formal way and really dissecting out the patient voice and carrying that forward to research is critically important. And then there's also been some work done in what's called SCAMPs, and these are things that are applied in hospitals where as a group you decide this is what we think should be a standard of care for most patients, and we're going to see why this works or does not work by collecting data on every patient. So I'd also just like to briefly talk about shared decision making, because I really think this is how we move forward. We have practice guidelines. We recognize our practice guidelines are very, very based on evidence, and there is not oftentimes very good evidence to guide us. So we sometimes end up in a world where we're still relying quite heavily on patient preference and values, even in our guidelines. So I think we need to work on how we disseminate these guidelines to patients and hear what they think about them. We need to, again, continuously stress the importance of patient-related outcomes. I think we also need real-world data. How do different drugs and things really work in the real world, not just in research where things are very controlled? And then again, coming back and really listening to that patient experience voice. And all of this collectively will help us get to better shared decision making, where we can really create tools that help us interface and have conversations with patients in a meaningful way. So this is just a little of what shared decision making looks like. So the clinician comes at this with the evidence that they have. Obviously, we all have our own clinical experience as well with shapes and forms, what we think we should be doing. And patients come to us with values. They have their own context experience. They live with ITP. They have their experience and their story to tell us. And we have to bring these together into a deliberate conversation. This may be with the use of decision tools. It may be with the use of online resources, and or the use of quality of life assessment in real clinical time. But this leads to a really deliberate conversation where these two things are merged together so that we end up with a decision that is evidence-based and patient preference-based as well. And that's going to be the most successful decision. That really is going to be the most successful therapy, because I think we all are coming to appreciate that probably no one therapy is best for all patients. So what we're really trying to do is, the benefit of treatment is different for each patient. I think we have to set goals at the beginning. Are we trying to stop or prevent bleeding? Are we trying to work on improving quality of life? And what does that look like to the patient? What would a good quality of life be? Are we simply trying to get the platelet count up? Is there a reason we need to do this quickly and emergently? Do we have a patient that has a significant history of bleeding, and so we're going to treat that patient a little bit differently? But we always have to weigh this against any of the negative impact of treatment, inconvenience, and cost. And what we're looking for at the end of the day is just a happy and healthy patient when we pull all of these things together collectively. So in conclusion, patient-related outcomes need to be applied to clinical research. Use in clinical practice can help facilitate communication between the patient and the physician, and shared decision-making can help to arrive at an individualized treatment plan that achieves patient goals while minimizing the risks. So thank you.